Good afternoon. My name is Anthony Powell. I'm a student at the University of Houston Christian University, and this is a Hsrv 7302 Program in Planning and Consultation in Mental Health. My professor is Amanda Ford, and this is my PowerPoint presentation for access to mental health treatment among vulnerable young adults. The problem analysis, the nature of the problem is the high prevalence and the coincidence of untreated disorder and the data-driven insight. As you see in my scope is a significant rate of anxiety and depression among young adults 18 to 25, with many reporting unmet treatment needs. Linked to the academy dropouts reduce work participation and elevates the substance use risk. The grounded in the nature for Houston statistics, as you can see to the right, shows the anxiety and the depression rate. Key barriers to access my PowerPoint is the cost and insurance gap, the inability to afford care, and the lack of coverage. The structure barriers, long wait times, provider shortages, and the rural challenges. Our stigma and cultural mismatches are perceived judgment, non-affirmative services. Our target population, as far as the definition and size, as you can see in my graph, the target population overlaps low income, racial ethnic minority, 10, 12, and 8. The definition is vulnerable young adults 18 to 25, low income, racial, LGBTQ plus SGM, unstable housed, and first generation students. The highest symptom burdens, these subgroup face elevated rates of mental health symptoms compared to the peers. And as you can see, the chart shows that the lower treatment uptake, documented disparity, and initiated maintaining mental health care. Rationalize why intervene now. The rise in symptom rate, it's increasing the prevalence of mental health disorder among 18 to 25 years over the last recent years. Also, early intervention mitigates the downstream effect on education and employment, which has a lot to do with mental illness. And the cost effectiveness improve access, reduce long-term system caused by preventing crisis in America care. Logic model, as my summary, is the input, clinical peers, navigation, telehealth platform, and community partners and funding is what we need. The activities in those inputs would be the outreach and screening, brief teletherapy, peer support, and referral pathways. And the outcome and the impact it would do, it would reduce symptom scores, higher retention in education, work, and long-term well-being. Our goals and our SMART objectives. Overall goals is to increase access to effective mental health care for vulnerable young adults 18 to 25. The objective is at least 6 months to raise the screening rate at the partner site of 30%. And our objective 2 and 3 is 12 months, increase treatment initiative by 25% and achieve a 3-point mean PHQ-9 reduction. We call that the SMART analysis, specific, measurable, achievable, relevant, timely. The program design, the core components, rapid access teletherapy, same as next week video, brief 4 to 6 8-week session models. Culture responsive therapy, CBT, ACT, adapted by the SGM and racial ethnic minority youths. Peer navigation in groups, community navigate, reduce stigma, and support treatment retention. The flow chart, as you will see, it's for outreach and screening. There's triad referral and also ongoing monitoring. Standardized measurements every 4 weeks with step-up care. Management formative evaluation, as we would use key metrics, initiating treatment, average wait time, attendance rates, data sources and canons, platform analytics and clinic record with minorities dashboard, and continuous improvement, quarterly reviews to adjust strategy and improve performance. Very much needed. Our management survey of the evaluation on the outcome would mean changes from the PHQ-9 and the GHD-7 at 3 and 12 months. Secondary outcome, treatment retention, satisfactory academic work status, equality and analysis that we would monitor, and evidence-based measurement aligned with the best practice outcome monitoring protocol. Very useful. Performance measurement and indicators. As we can see, we have a process indicator, we have a clinical indicator, and a quality indicator. Very much needed. The impact for long-term outcome. The coverage expansion, increased treatment coverage for young adults within 2 to 5 years. It reduced burden, lower prevalence of untreated depression and anxiety, and system benefit, fewer crisis cases, reduce long-term health care and social costs. And as far as our budget, high-level items, clinical peer navigation program manager salaries on personnel part, and technology, the telehealth platform, license, secure data analytics, and operational outreach, training, supervision. Contingencies, 10%. Funding and sustainability would use government and foundation grants, pilot funding. Our ongoing revenue would be insurance, Medicaid billing, and institutional partnerships. And supplementary support be sliding scale fees. So, this is the conclusion, and the next steps is integrated approach, immediate actions, and ongoing monitoring. Baseline data collection, monthly formative reviews. And that concludes my PowerPoint slide. Thank you for joining, and these are my references. And may God bless you, and have a nice day.